Wonderful. Good morning, everyone. Again, my name is Brittany Stratton. I'm a licensed clinical social worker with Brain Injury Services, and I provide outpatient mental health counseling to individuals with acquired brain injury.
I'm Joy Keppen, and I'm a licensed clinical social worker, and CBIS stands for Certified Brain Injury Specialist. I'm the counseling manager at Brain Injury Services, and I also provide services, outpatient services, to both our clients with brain injury and their caregivers. Um, and I'm starting this slideshow if you're ready. So I'm going to go ahead and tell you not just about me, but a little bit about Brain Injury Services, the organization we work for. I wish I could say we are in sunny Northern Virginia, but we've had a lot of rain over here on the East Coast. And so we are not on the coast per se, but we're dealing with some of that rain. But we are right outside of Washington, D.C. So we are in the Washington, D.C. metropolitan area. Our organization serves Northern Virginia and surrounding counties. So we go down a little bit further outside of the northern part of the state, but mostly most of our clientele is up in this close to the DC area. Our organization provides free services. We're always happy to be able to say that, and that's thanks to a lot of different funding sources. And we actually provide case management as an organization, vocational support, skills building with some licensed occupational therapists. And we have 2-day programs in our organization. One is in Fredericksburg, Virginia, and one is in Fairfax, Virginia, which is further north. And Brittany and I, as Brittany said, we provide mental health therapy for individuals with brain injury and their caregivers. And typically we get our referrals internally. So our clients are also working with a team of other individuals. So the goal of this training is for you to really learn more about the basics of brain injury and really how it impacts those individuals with the injury and those who care for them and about them, as well as strategies for working with them. Our hope is that you will learn how to identify brain injury and its causes, but mostly how to identify the symptoms of brain injury, so you'll be able to understand better how to apply the strategies that we'll share with you when you're working with individuals with brain injury. So next, we're going to do a Zoom poll to try to learn a little bit more about you, our audience. And so I take a few minutes to answer the questions. Wow. And if we're about done, Mary, I don't know if you end the poll or if I do, but I do actually have it on my screen.
Did you want me to end the poll?
It looks like everyone's answered.
Okay, I will end it.
I think I can share the results, looks like. So it looks like the majority of our audience are mental health therapists, but we do have a couple of other roles that you all play, and there's a family member of a person with a brain injury as well, and then some other. Feel free to share if you want to, what other means in the chat if you'd like to, just to help us get to know you a little bit. And I'm going to stop sharing this. results. Thank you for participating. So I'm going to start out by kind of sharing a little bit of a disclaimer with you. So Brittany and I are not neurologists, obviously. We're not researchers, but our information comes from sources that we in the brain injury professional community utilize that give us the best data that we know to find out about how often brain injury is happening and some of the other statistics about it. And we often do use the Centers for Disease Control for that. We are clinical social workers, as we said, who have learned from many hours of experience how to best work with each unique individual with each unique brain injury, and whose symptoms and treatments may be similar across the board. So that's where our primary examples are going to come from, and the information about effective strategies, they're strategies we have used with our clients. With that said, I'm going to start out a little bit of brain injury 101 for you, and Brittany's going to continue that. And it's really an overview of how our brains are supposed to work. But before we start that share that information, I want you to see some of these statistics. So about 190 people per day died from a TBI or traumatic brain injury related incident in 2021. And these are the ones that are reported. There are a number of injuries that happen that, of course, aren't reported. And so the number is likely much larger. There's also a common factor in why they're not reported in that many times when someone's in an accident, there are a lot of other injuries that occur. And the most pressing visible injuries are the ones that are addressed, and brain injuries get missed more often than you might think. This is also true, not just for statistics, death statistics, but for those who are living with a disability because of it. Some individuals that we've worked with and that I've met didn't even find out that they had a brain injury for many years after the injury actually occurred. They just go back and piece it together and then find out that things have really changed and it's not just physical changes. So you'll also see here that there are, I'm going to move to the next slide. Sorry. It does talk about being 75 and older, but I'm going to move to the next slide before I go into that because there's more information about age statistics here as well. So an estimated 2% of Americans are living with a disability because of a brain injury. And that's really the people that we're going to be talking about today. You can see on the slide that there are certain age ranges where people are at higher risk. Probably not a surprise to you that those between the ages of 15 and 24 are at higher risk. Think about why that might be. Sports injuries, young drivers, just underdeveloped brains or not fully developed yet. And there are a lot of things that can happen when somebody is maybe doing risky things. They're at higher risk. There are also some statistics showing that if you're over a certain age or under a certain age, falls are a primary reason for injury and some other causes. So age is definitely a factor. Gender can be a factor. I always think about the fact that car insurance is higher, at least in this state, for males of a certain age, and I have two of them. So there's a reason for that. There's a difference in development, and there's a difference in risky behaviors, et cetera, et cetera. And the statistics just show that. But make no mistake, brain injury really knows no bounds. It can happen to anyone at any time. So I'm going to go into a little bit more about acquired brain injury because that's really what we're talking about here. And that's an umbrella term for any brain injury that happens after birth. There's two different types. And one is traumatic brain injury, and the other is non-traumatic brain injury. fairly self-explanatory, but I'm just going to go into a little more detail with the traumatic brain injuries to start with. And they're either closed or open. A closed injury is one that's penetrating, so anything that happens inside the skull. And an open is penetrating and generally a skull fracture or in some way from the outside, there's a penetration that causes the injury. Here's a list of causes for brain injury, TBI, traumatic brain injury, and falls is on the top of the list. This is not necessarily in order, but it is one of the primary causes for brain injury, not necessarily sports injuries or accidents. There's a bunch of different types of traumatic brain injuries. Some are very common. We know concussion. Some people actually don't know concussion is a TBI. Contusion is when there's blood underneath the skin. It's like a bruise on the brain. Coup contre coup is when the brain, which is kind of floating around in fluid inside of our skulls, obviously attached, but still moves around. And there's good reasons for that. But when we have whiplash or a hard enough hit to the head, it can cause the brain to bounce back and forth. And that's what coup contre coup is. It's when you can have damage to both sides of the brain because of that bouncing. You can also have more broad injuries or a global diffuse injury if there's a lot more violence to the brain. And, shaken baby syndrome, sadly, is one of those. Brain injury occurs along a continuum. And I'm sure you've heard of a mild brain injury and severe brain injury. You may have heard of a moderate brain injury as well. Most of the time when somebody sustains a mild brain injury, they do recover fully. No lingering symptoms at all. But there are definitely people, even with a mild brain injury, who may have lasting symptoms that are permanent. And so the key is loss of consciousness, which is listed here as LOC, is less than 30 minutes for it to be called a mild brain injury. And it often doesn't show up on a scan. So people may or may not actually see that there's been injury because it's mild enough it doesn't show up on a CT or MRI. PTA, which stands for post-traumatic amnesia or disorientation, usually lasts less than 24 hours. And there's not likely to be a need for therapy, although I'm not sure about those who are listening if you have concussion clinics in your area, but sometimes they will manage symptoms for a little while right after the injury, and someone will still fully recover. But typically, it really doesn't take a super long time for people if they're going to fully recover. A moderate injury, loss of consciousness has to be more than 30 minutes, but less than 24 hours. But post-traumatic amnesia can last for up to 7 days. Recovery tends to take longer, and individuals are more likely to receive some sort of rehabilitation. It might be cognitive rehab, which is usually a speech therapist that provides that, or other therapies that may help them with memory, focus, etc. Severe injuries are the ones where you hear someone's been in a coma. Usually there's a prolonged loss of consciousness. Post-traumatic amnesia lasts for more than 7 days, and they may or may not have a physical disability. And we'll talk a little bit more about the invisibility of acquired brain injury later, but they're usually transferred to a rehab where many people have to learn to walk and talk and do a lot of things over again. Not that they don't improve and get better, but the amount of rehab is a lot greater and takes longer. Non-traumatic brain injury, which is an alteration in brain function or other evidence of brain pathology, must be caused by internal factors. The most common is stroke. Sometimes you'll see CVA or cerebral vascular accidents on a medical report. And stroke is the most common type of non-traumatic brain injury. And there's a couple of types of stroke. The most one that we hear of the most, where there's an artery blocked or blood clot that blocks the flow of blood to the brain, is an ischemic stroke. And there's actually something called a transient ischemic attack, which is like a mini stroke. Same reason, but it actually, the TIAs usually don't show up on a scan. The ischemic strokes usually do. Hemorrhagic stroke is when bleeding occurs inside the brain. It's not quite the same, but it can have a very similar impact. Other causes of non-traumatic brain injury include aneurysms, exposure to toxins, and that does include chemotherapy over long periods of time. It also can include infectious disease, chickenpox, not always, obviously, but chickenpox, meningitis, and even COVID-19 can cause brain injury and long-term cognitive effects. Anoxia is when the brain is deprived of oxygen, and that can happen from various things, including heart attack and near drowning. And that tends to cause more global damage, where it's not necessarily one area of the brain, like when a stroke occurs, but there's impact on various and sometimes unknown areas. It's really the symptoms that give you a clue as to where damage might have occurred. I think we're going to wait until after to answer questions, just to get through a lot of material. But we will have plenty of time, so hang on to those questions. So strokes also, Centers for Disease Control tracks that as well. And every 40 seconds, someone dies of a stroke. Large number of people in the United States who have strokes, and most of those are new strokes. Some of them are people who've already had a previous stroke. So you can see here that most are ischemic. And it is considered the leading cause of long-term disability. And now I'm going to turn it over to Brittany, who's going to give you some neuroanatomy.
All right. So, yes, we're going to look at the different areas of the brain. And again, don't want to overwhelm you with emotion. So, we're just going to give the highlights. And of course, the information that we're going over, you guys will have access to the slides. And if you have any questions, we'll definitely be able to follow up towards the end. So, over the next several slides, we're going to look at the different lobes of the brain, starting with the frontal lobe. And so the frontal lobe is considered the CEO of the brain. So responsible for that planning, attention, organization, focus, working memory, socialization, personality, initiation, and inhibition. So a lot of control there. And damage to this part of the brain can lead to changes in personality, behavior, decision making, and as well as impaired executive functioning. Shifting over to the temporal lobe. And so the temporal lobe is responsible for emotion, speech, as well as aspects of learning. So for emotions, the amygdala is also located in the temporal lobe. Again, amygdala, the brain's fear center, controls that fight, flight, freeze response. And then you also see with speech that language comprehension, speech, and language production. Another part embedded in the temporal lobe is the hippocampus. And so that plays, again, a major part or role in learning and memory. Temporal lobe is also responsible, again, for that modal learning and procedural learning. And so damage to this part of the brain can result in difficulties with memory, language comprehension, auditory perception, visual recognition, and can also, again, that overlap cause personality changes, including altered emotional responses. Due to the temporal lobe's role in processing sensory information and integrating it with memories and emotions. And so that's why you can see that altered emotional responses. And again, it says damage here can cause that increase in aggression. That can be noted with a temporal lobe injury. And then with the parietal lobe, again, this is responsible for your sensory cortex. So the part of the brain that processes sensory information from the body's sense organs and combines it into meaningful experiences. So it's responsible for the perception and recognition of sensory stimuli and plays a key role in behavior, sensation, and perception. Another aspect controlled by the parietal lobe is proprioception, which is the body's ability to sense its own position and movement in space without relying on visual input. So it's an automatic process that's crucial for balance, coordination, and just really many everyday tasks. And then you also have, again, aspect or responsibility of parietal lobe is attention and awareness. And so what you can see with damage to this area of the brain, difficulties with spatial awareness, sensory perception, recognizing objects by touch, distinguishing left from right, problems with writing, calculation, and trouble with self-care tasks like dressing due to impaired body awareness. So essentially, an injury to this part of the brain can lead to issues of how you perceive and interact with the world around you. And then shifting over to the occipital lobe, again, that is responsible for your visual processing. So part of the brain that receives and interprets visual information from the eyes, including color, shape, and motion perception. Damage to this lobe can result in visual impairments, including blindness, blind spots, or visual distortions. And shifting gears slightly, we're going to look at the limbic system. So, the limbic system is a group of structures in your brain that regulate your emotions, your behavior, motivation, and memory. Damage to the limbic system, again, issues with memory, mood swings, anxiety, depression, aggression, problems with sexual behavior, potential behavioral abnormalities, depending on which part of the limbic system is affected, and essentially disruptions to emotion regulation and cognitive functions like memory formation can occur. And the last two parts, looking at the cerebellum and brainstem. So cerebellum, primarily responsible for coordination of movement, maintaining posture, balance, muscle tone, motor learning. It assists with vision and eye movement and plays a vital role in language and attention. Damage to the cerebellum can result in difficulty swallowing, walking or balancing, inability to control eye movements, trouble with speech, and tasks that require fine motor skills. Brainstem, again, responsible for vital functions of life, such as breathing, blood pressure, heart rate, temperature, consciousness, sleep, balance, movement, and swallowing. Damage here can result in movement issues. So that's the difficulty walking, lack of muscle control, abnormal eye movements, coordination problems, speech and swallowing problems, balance issues, breathing, heart issues, vision, hearing, sleep, sensory issues, and consciousness issues. This is what Joy was referencing when you look at that spectrum. And so more on the severe side, you see that with injury to the brainstem. So while some people can fully recover from brainstem injuries, others may suffer irreversible debilitation or even death from those types of brain injury. And now we're going to look at possible symptoms after brain injury. So the brain is everything that we are. It controls every function, but we can summarize the changes that we see into the three categories of physical, cognitive, and emotional. And so again, because there's a lot of overlap and we kind of breezed through that earlier, I'm going to go through this pretty quickly. But so the physical changes observed after brain injury, again, vary in intensity, frequency, duration, and it depends on the type of person, on the person, the type of injury suffered. And so again, the symptoms can range from, as you can see, mobility, balance issues, motor functioning problems, sleep disturbances, neurological issues such as seizures, vision, and hearing changes. Cognitive changes observed after brain injury, again, also vary in intensity, frequency, duration, depending on the type of injury. And those cognitive symptoms range from issues with memory, concentration, attention, learning comprehension, communication, changes with insight awareness. You see some overlap with the cognitive and physical, with sleep disturbances and overall executive functioning. And then lastly, looking at the emotional and behavioral changes observed after brain injury. And so, once again, vary in intensity, frequency, duration, and the manifestation of the changes depend on the person and type of injury. And these symptoms can range from personality changes, mood disturbances, emotional dysregulation, changes in emotional expression, issues with impulse control, decreased social and self-awareness. This is where we see a lot of overlapping symptoms between mental health disorders such as major depressive disorder, generalized anxiety, PTSD, and brain injury. And so on this last slide here, to kind of wrap up this section, looking at the behavioral emotional facts, something I just want to pull out or just highlight is that emotional behavioral changes observed after brain injury can exacerbate pre-existing mental health symptoms, or new mental health symptoms can develop. And so the duration and intensity of the mental health symptoms vary based on the type of injury. Again, you'll hear me say that a lot because no brain injury is the same. It's very unique to the individual, even though there are some common threads, but again, it will be unique to that individual. Other factors that can influence symptom development and improvement include environmental factors such as a person's adjustment to living with what may be a permanent disability. So their ability to cope after the fact is a factor as well. Again, those environmental situation factors. What do protective factors look like? What do risk factors look like when we're talking about post-brain injury recovery?
All right. Thanks, Brittany. So, title of this presentation is Effective Strategies, and here we are. I hopefully that some of that background will be helpful as we go through kind of how we can accommodate, how we can assess and treat those with brain injury and mental health issues. So I have discovered that in working with individuals with brain injury, after several years of doing that, that traditional assessments are lacking in being able to really identify when something may be actually a brain injury rather than mental health, because there is so much crossover there. And so sometimes you will have an assessment that asks questions that actually could just be because of brain injury and not mental health. And I'm going to explain that a little bit more. So, sleep disturbance, for example, is very common after a brain injury. Not always sure why, but it's very common for our clients to have sleep disturbance for various reasons. Some of them may be mental health issues, but many of them are just the way the brain is functioning, and it's a change from previous level of function. Flat affect, you may see this a lot with, you might not be surprised to think about like stroke. Sometimes paralysis of the face or muscles, weak muscles may appear to be flat affect, but sometimes it's just an emotional disconnect that happens after brain injury. And it might not be an indicator of how the person is feeling at all. It can be tricky to figure that out, but that is definitely something that is a physiological response sometimes after brain injury. Slow processing can really kind of look like something else sometimes. It can appear that the person's not engaged. It may be might even look like drug use or slow processing because of maybe a learning disability or low intelligence or difficulty reading or whatever it might be. But the person just takes longer to process auditory, visual information, and it may be hard to kind of identify that unless you're aware that there has been a brain injury. Sometimes we assume that memory is a declining condition like dementia, but it's not always permanent, and it doesn't always happen the same way from day to day with brain injury. There are some consistent patterns sometimes, but it oftentimes is impacted by sleep, which, as we said, is common. Disturbance is common with brain injury. It may depend on how many tasks are on a person's activity list that day. And so there are many different factors that make brain injury types of memory challenges sometimes more inconsistent. And along those same lines, fatigue can be a symptom because of an overtaxed brain. If you can imagine just having too many things on your plate, and how sometimes it's hard to be at 100% at full capacity when you've just got way too many things going on. In an injured brain, sometimes it can feel like that with only a couple of tasks because of the amount of mental and even just energy, physical energy it takes to process a lot of the steps involved in the things that we do automatically if you don't have a brain injury. So take a look at this slide. This is a screenshot of major depressive disorder, and look at some of the symptoms on this slide in light of what I just shared and think about, gee, could that maybe be a symptom of brain injury rather than necessarily depression? I'm going to give you just a couple seconds to look at that. And we're not taking questions at this point, but I'm just gonna kind of guess what you might have noticed, which is insomnia. I mean, we just talked about that sleep disturbance is common after brain injury. Fatigue, again. We may look at that, not knowing there's a brain injury, and think, well, somebody's sleeping a lot, they're depressed. Well, somebody may be sleeping a lot because their brain is overtaxed, their brain is still healing, and it might not have anything to do with really their mood at all. Focus and attention is definitely something that can follow a brain injury and is sometimes a new symptom. It's not necessarily something that is diagnosed as ADHD, but it's a post-injury executive function issue. So that's where the diminished ability to think or concentrate. That could definitely be brain injury. So not everyone knows they've had a brain injury, and that's when it becomes even more tricky. You might see this list here, clients who they're more forgetful. Their life is kind of all over the place, and they're just say things are always happening. I can't find this, I can't find that. They're just missing appointments regularly. They're easily overwhelmed. Again, you might not know they had a brain injury, so you could be wondering if this is all mental health. But there may be more information that we need in order to determine what's really going on. So because they don't know they've had a brain injury or maybe did not have it diagnosed, we have to ask other types of questions. Ask about accidents, domestic violence. You might ask about something like stroke or TIA because people don't always think of that as causing brain injury. Viruses, like I mentioned earlier, sometimes there are lingering neurocognitive effects. And if somebody had something like that and then noticed changes afterwards, or have never been quite the same, never got over the fog, have had more difficulty in school, etc., at work, you might want to consider brain injury. And one of the things that we often request, and is one of the best ways to at least tease that out if you don't actually have medical documentation of a brain injury, is to have a neuropsychological evaluation done, and it helps us to understand the functionality of the brain. And usually by history and report, they can also figure out, was there a time when these things maybe weren't the case and they noticed a big difference? Again, cognitive changes, but that's more of a measurable way to determine, has there been some sort of change? And again, gathering a good history is going to be really important. So it might look like a psychiatric issue, like I was saying earlier, if we don't factor in the brain injury, and here's why. So anxiety is anxiety. I mean, it's an emotional issue. It's something that people need to learn to manage, but sometimes it's hard to figure out where it's coming from. And I've had clients who were afraid to cross the street. They were afraid to be in a particular store because that's where they were when their stroke occurred. And sometimes if you don't know enough of the brain injury history, or you haven't gotten to that point, you don't really know that there was an incident. It may be difficult to understand, why are they afraid of being crossing the street? Why are they afraid of this or that? And sometimes there's even more mystery when somebody was unconscious. They had an accident, they were unconscious, and they don't really have any memory whatsoever. They only know what they've been told. I've had clients who are many years later, they have kind of a freeze response when they hear a helicopter, or they get upset when they hear sirens or when they see flashing lights. And I had a client who had a trigger from sirens and flashing lights, but did not remember her accident at all. Um, those kind of things can be kind of buried in there, but it takes a little bit of research to figure out where is this coming from, and that helps figure out how to treat it. Avoidance of others might not be related to mental health as much as heightened sensory issues that are a result of the brain injury. People wear sunglasses inside because they have heightened sensitivity to light. They might have migraines as well, and sometimes that's something that they may share with you, but they may also have heightened, something called hyperacusis, heightened sound, and they may also have communication or processing issues that make it really difficult to be in a busy place with a lot of people. And I actually never noticed that a lot of grocery stores play music until I started working with people with brain injury who couldn't shop in a grocery store with music because it was too distracting. They can't sort out what to focus on when there are too many stimuli to focus on. And so it becomes overwhelming and exhausting and can really be emotionally upsetting. There's a phenomenon called pseudo-bulbar effect, and I'm going to tell you a little bit more about that. You may have heard of it, but it can present as kind of a inappropriate crying, laughter at times that really don't even make sense to the person themselves. And so according to the Mayo Clinic, it's characterized by episodes of sudden, uncontrollable, and inappropriate laughing or crying. So there's no real connection to what's going on. And it typically does occur in people who've had some sort of an injury or some sort of a condition, neurological condition. And I actually had a client who was diagnosed with this, and I met her in a group setting. And so she was pretty early in her recovery from a very major car accident, and she would just start crying. And she didn't really know why, but it was because her brain was just, it was just kind of short circuiting, if you will, and the emotional center just was acting out, I guess is how you could describe it. But oftentimes this gets misdiagnosed as depression, even though the crying is not really associated with a particular event and the person doesn't even know why they're crying. It does get misdiagnosed. So I did want to point it out today. So there are a few other brain injury symptoms that might mimic mental health issues. So again, social avoidance, I use the example of being in a crowded place, overstimulation. When somebody has word finding issues, that's also another reason why they might avoid being around others, because they don't want to have that happen to them. And they may know they have that issue, and it may not show up all the time, but it does show up when they're anxious. And so they may have to test it out and find out that when they're in a situation with somebody new that doesn't know them very well after injury, or someone who doesn't have any idea they have a brain injury, and we'll talk about that too, that's very invisible, they may not want to put themselves in that situation again where they can't find words because they're embarrassed. Depression is common due to loss of previous identity and all kinds of things, job loss, friends, and we'll talk a little bit about that when we talk about the grieving process. Talked about the flat affect already. I have a client who has vision issues who can't look at me, and it's because she sees two of me. She has double vision. And you can imagine if that's what you see 100% of the time, there's no way to really correct it. She just has to figure out how to live life with double vision. And so you have to kind of take that into account when you have something like poor eye contact, reading issues. People don't always want to admit what it impacts because it's really hard to accept. Vestibular issues. More than one client with a brain injury has been stopped by law enforcement because it was assumed they were intoxicated. I've heard these stories before. Sometimes it can be really, really helpful to be able to have something in writing that says to hand over to an officer. And I'm going to give you a couple of websites here where they can have just enough information that identifies that they have a brain injury and what they struggle with, whether it be speech issues, dizziness, balance issues, a variety of things that could come across as being problematic unless someone really understands that they have a brain injury. We have a couple of clients in our organization who have gotten these, and they speak very highly of this. And it's customized, but there are a couple of organizations that will do them for you for free. And one is at brainline.org, and they have lots of great information about brain injury as well. But they have free ID cards for people with brain injury, which obviously are customized. And then there's a law firm, and their website is brainlaw.com, and they actually provide them for free as well. And we have had clients order them. And again, I've seen them. I've had clients show me what they look like. And it sometimes, especially if they have speech issues, it can be really, really helpful to have that information to share. So I am going to talk just briefly about aphasia. Let me go back. That same little icon there. So there's two different types of aphasia, which is a speech issue. It's a brain issue. It's not an intelligence issue. So it's really, it's because of damage to those speech areas of the brain that we looked at earlier. And expressive aphasia is when someone has word finding issues. They understand what you're saying completely, but when they're responding to you, you can't necessarily tell that they understood what you were saying because they're having trouble explaining that to you. Receptive aphasia is when they don't understand, and sometimes people have both. And I have worked with clients with both. It can be very tricky. It's like learning a new language, but it is possible. And there's more information about aphasia on asha.org. But I'm going to show you one more kind of an illustration. So sometimes it can seem like, again, you're the one who knows what's going on and they are not. But oftentimes I'm on the other side. I'm the one who is confused, not the client. They know exactly what they're thinking and exactly what they want to say, and they completely understood my question. And so it can take some time to figure out how to best communicate. And that website I shared it has a lot of information as well. And lots of different places. We have a place here called the Stroke Comeback Center, and there are a lot of people there with speech problems. And they learn from each other too how to communicate with people. And this is Brittany's.
Okay. Alrighty. So we're going to look at accommodations for behavioral emotional treatment after brain injury. And please note these accommodations it's not anything you have not heard before, but we just want to highlight them and encourage you all to keep these strategies in the forefronts of your minds when working with this population. Again, as they prove to be helpful to accommodate for the physical, cognitive, and emotional changes experienced post-brain injury. So one strategy that can be helpful is prompting, and it's used to guide behavior and help an individual learn a new skill or engage in a desired goal. Helpful when addressing executive function changes experienced post brain injury. And so examples of prompting include visual, such as pictures, symbols, written instructions. Again, I may use example, I may use visual images to guide a client through the steps of a morning or nighttime routine to support them with setting up or re-engaging in a system that they used to do prior to brain injury. Another example of a prompting is verbal. So those would be cues, praises, instructions, redirection given verbally. An example could be when a client enters into my office and then kind of hovers in the doorway because they're confused as to what do I do next. I may gently throw out the verbal cue of please sit wherever you feel most comfortable, just to prompt them to yes, go ahead and grab a chair, and then we'll get started with today's session. Modeling, again, another form of prompting. You can do that through imitation, role playing, or chaining, and that's just the breaking down of a task or activity into smaller steps or chains in a process. And then physical, pointing, facial expressions, the use of facial expressions lets someone know that yes, they're on the right track, or let's try again. Let's think about that. So those are just some, again, an example of accommodations to think about when working with this population. Another accommodation would be repetition, repetition, repetition. So that is a big one. And just a little bit about repetition and its importance in recovery. It's an important element of recovery after neurological injury. And this is because it sparks neuroplasticity, which is the brain's internal mechanism of strengthening frequently used pathways and functions. When a thought or action is practiced through repetition, specific neurons in the brain communicate by firing repeatedly. The more these neurons fire together, the stronger the communication between the parts of the brain. So in a clinical setting, teaching and practicing a new skill within the session multiple times in an effort to work toward mastery for this client. And of course, mastery is defined based off of the client's ability and deficits. And so another accommodation would be to offer options. This is helpful when working with individuals who struggle with word finding, as Joy was talking about with aphasia, where it may, the client is able to understand and comprehend clearly what you're saying, but unable to express themselves, or again, use of that communication to let you know what's going on or how they're feeling. And so this can help with honing focus and mitigating anxiety and frustration related to barriers in communication. Another accommodation would be change of modality. So exploring different options such as expressive art therapies, the use of music, movement, meditation, yoga, mindfulness, writing, and or technology as a way to engage a client and support them with expressing themselves and processing thoughts and feelings. And then shifting gears a little bit, we'll look at behavioral concerns after brain injury. And so one would be interrupting. And this could be due to memory deficits and that diminished social and self-awareness. And so a tool to utilize or that you can utilize would be the parking lot. I know there are many terms for the parking lot, but it's pretty much the idea of someone brings up something and you acknowledge what was said and say, you know what, we'll circle back to that. I'm going to hold on to that thought. And so if you use, let's say, visual aids in session, whether it be a whiteboard or the large post-it notes, you stick it up there and let them know that you're going to circle back. And so that's helpful to, again, redirect focus, especially if you're in a group setting. It also helps with maintaining the structure of what you have going on within that session, as well as setting a boundary. So you're also teaching and doing that as well. Another concern you may see would be resistance. And I encourage folks to ask the important question about whether this resistance is an issue of skill or a matter of skill versus or will. Again, thinking about that, what we label as resistance or non-compliance may be the result of physical, social, emotional deficits that's impeding learning, visual, verbal processing, comprehension, retention, and executive functioning. And so if that's the case, it's important to support by teaching, rehearsing when introducing new concepts, and asking questions to learn more about the potential barriers, what's really going on there, as opposing to assuming this client just doesn't want to engage. Another behavior just to be mindful of is that follow through. And again, question to ask, is it an issue of skill or will, right? So strategies to address this when looking at that, again, use of the previously discussed accommodations, reminders, and also to the provider's consistency is really important with that. Again, scheduling clients with a consistent date, time, weekly. Also, too, if length of time a session is an issue, shortening them. I know we're able to offer 30-minute sessions in certain practices that may not be feasible. But again, just thinking about that is really to meet the client where they are. So starting where they are is really, really important when we're talking about accommodations and how to address some of these concerning behaviors. Also to location as well. So just being consistent in how you're showing up for that client as well as what the service that you're providing.
Thanks, Brittany. Um, So a really important part of this, as you can imagine, with all of the changes that we've talked about that can happen after brain injury and all of the challenges, some of which may be an exacerbation of pre-injury concerns, and some of it's brand new. And I just met with a client yesterday who was talking about her executive function changes, and it's been 5 years since her injury. And it was an accident. It was not a stroke. It was a result of an accident. And so there's a lot that goes with that. The nature of the injury, the changes after injury, and what the person was like pre-injury and when it occurred. And so it can be kind of like a death. And that's why we talk about grief and loss. But it's also why and here's some of the reasons. Here's some of the things that they lose. My client was saying she was listening to somebody talking about his executive function skills and how well she could relate to that. She still works. She went back to her job, but she can't do it the same way. And she doesn't do it as quickly and as easily. And this guy was talking about, well, yeah, this is just my life. And she said she could identify with a lot of it until he said, I've just been this way my whole life. I've had ADHD my whole life. And she was thinking, I didn't have ADHD or executive function issues until I was 50. And so if you can think about what her life was like before and the grief and loss associated with what her life is like now and what she's lost, that will give you a really good idea of what they're going through. And so it's the same stages of grief that people go through when there's an actual death. It's a death of self, it's a death of abilities. It's very similar, but yet it's different. And so sometimes it's referred to as ambiguous loss because there's really not a sanctioned process for this. We don't have a funeral for loss of self, for loss of job. We don't have quite the same experience. And sometimes others don't understand. They look at you. I've heard this so many times from clients who say, people say you look fine, but they don't feel fine. They know they're different, but others are praising them for doing so well. And they look great, but what's happening is invisible. It's a lot like a mental health issue. And when they go together, it's a really frustrating place to be. So they go through the same types of process that anyone would go through. And as you all probably know, the stages of grief are not linear. You can go back and forth. You can think you've gotten to a certain point and then you kind of go back to something else. And so a lot of times when it comes to brain injury, they deny changes have occurred at all. And this client I was just meeting with, who's 5 years out from her injury, says she still struggles with acceptance. She likes being in denial. She calls it her happy place. And yes, there is a place for denial sometimes, but ultimately, she is not really willing to face the changes, and that can cause more frustration. Um, Sometimes people will get recommendations from a doctor or a speech therapist or someone to say this would be a helpful way to accommodate that. So you don't have to remember, you can do this. But people sometimes don't want to acknowledge that they struggle with it. And so that makes it difficult. And they just maintain that nothing's changed, everything's the same, I'm fine. There is a difference between denial and something called anosognosia, which is not just a brain injury thing. So you may be very aware of what this is, just in case. Anosognosia is really when someone is not even aware that they have an injury or a disability. They just don't have awareness. And sometimes it happens in right hemisphere strokes, and sometimes it's referred to as a right hemi stroke. And then those of us who've worked with that know that there very likely could be a lack of awareness that anything's changed. They just think they can do the same things, or they don't even realize they have a disability. And we know anger is a necessary stage, but it is not fun. And a lot of people don't like feeling angry. But my client and I were going through all of these stages yesterday. She's new to me. So we've just really started narrowing down what she wants to focus on. And it is the grief. And the anger part, she doesn't like feeling angry. But what she said was, what happened to her wasn't fair. And it's not. It's not fair, and it's something that people get very frustrated about. What also may be not fair is lack of access to treatments that they need because of varying issues, varying factors. People may get really angry at a doctor who's telling them that they can't or won't be able to do something. And we tend to tell clients, don't necessarily believe that. And I sometimes get frustrated myself when people do that, because they really don't know. I've seen people change and progress years after injury, but there are times when things are permanent and they don't want to hear that from anyone. There may be times too that they're angry with the person who caused the injury. Sadly, we have clients who were injured because of distracted driving, drunk driving, people walking across the street and someone is distracted while driving and hits them. We hear lots and lots of different types of stories, but it's understandable that someone would be angry. But what I tell people is obviously you can't stay there. It's not going to help. But it is oftentimes out of character for someone it could be the caregiver as well, but for the person with the injury, it could be really out of character. So others don't understand. Bargaining. So they believe maybe they don't have to go through grief, or maybe they're trying to just figure it out. And if I could make sense of this, then maybe I don't have to deal with all the consequences. Obviously, when people start to realize that this is my quote, new normal, which some people can't stand that term, and some people use that term to define their life after brain injury. It's difficult to face that this is the way it is now. I can't work, or I am not able to do the things I used to love to do. My brain won't allow me. That can definitely lead to, and often does, lead to depression. Wouldn't we all love to be able to say, okay, everyone gets to acceptance? My client is still dealing with that 5 years post. So that can be really hard. That being said, she has accepted some things. And so it's a back and forth process. Again, the emotions do begin to stabilize. They start to come to terms with this new normal. And the key is they start moving forward from where they are now. They don't necessarily stay stuck. And there is a 6th stage of grief. And I went to David Kessler's workshop several years ago. It's before COVID, so I can track it, like 2019, sometime around there. And it was based on this book that he wrote called Finding Meaning. And it was also based on this book that he wrote, was based on his experience with the death of an actual person. But he does go into, in his book, other types of loss. It's not just the death of a person. It could be loss of a job, divorce, loss of a relationship, different things. And what he talks about, and he was actually had this 6th stage he got Elizabeth Kubler-Ross's blessing. They worked together on it. And she passed away a few years ago, but he did talk to her about it. And she kind of, sanctioned this as, yes, this is the 6th stage of grief. And giving back is part of finding meaning. And the way that some of our clients do this is speak out about brain injury. Let people know, drum up awareness, go to an advocacy day, either on the Hill in Washington, D.C., since we are very close to D.C., or Richmond, our state capital, and advocate for funding, advocate for different policies. We recently had a bunch of clients go down on a bus with us, and we advocated for higher pay for people who are helping people with brain injury, and that includes aides, because we were struggling. There's a lot of difference from the top of the state to the bottom of the state and all over the state. There's a lot of variability in cost of living, and it's difficult to find help that is willing to stay because there was really a disparity in what they were being paid. And so the clients themselves went down and told their stories to their senators and representatives, and they accomplished it. They were able to get increased funding in our state for people with brain injury, and that's really rewarding for them to be able to give back. Um, it helps them, but it also helps others, and there were caregivers there as well. Um, Providing support in a support group to one another. That's another way to find meaning. Well, I've had clients say, I would not have met these people. I would not have connected with this person and recognized I wasn't alone in life, let alone in this situation, if this hadn't happened. Nobody would wish for it to happen, but focusing on what they've gained from it for many of my clients has really actually helped them to get through it. Brittany's going to talk about the caregiver.
Alrighty. So we are going to look at again caring for the caregiver post-traumatic brain injury. And we're going to start with a quote from Abby Maslin. And I'm just going to read this out to you all. And it simply says, "The thing that's true about every brain injury is that it happens without warning. There is no preparation, no easing into the idea. Families are not given time to gather their resources or ready their minds for the challenges ahead. Rather, TBI is an explosion, transforming the lives we expected to lead indefinitely into something hardly recognizable. It is shock on a scale few can imagine." And Abby Maslin is a blogger. She's an author of Love You Hard, and it talks about her and her husband's story and how they redefine love and marriage post brain injury, her husband's injury. And then we provided, I believe, the resource or the link to Brainline. And again, they're a national multimedia project offering information about resources about preventing, treating, as well as living with TBI. And so, again, a great resources to check out if you are interested in receiving more information about them. And so, a little bit about the caregiver experience. Again, a host of social emotional changes include grief loss, as Joy was just talking about. That is just not specific to the individual with TBI, but also to their loved ones. I saw briefly through the comments of someone who, again, processing through their own loss of who their loved one was. And so that is, yes, it's very real. Isolation, that change in community. You may have people or individuals not know how to interact or support you. And based off of your new role, again, some loss of identity there for self. If you've had to pull out of certain things that you used to do as a caregiver. Something else that can happen is the development of new or worsened behavioral health issues. So again, experiencing your own mental health changes or struggles, and also ultimately burnout. So these are some things that caregivers can experience and are susceptible to. And so, how do we assist? How do we support the caregiver? Community, community, community is super important. So, support groups, don't underestimate the power of peer support, self compassion, adopting realistic expectations of yourself, and
I think that Brittany's computer is frozen up and she might have to log off and log back in.
Okay, I wasn't sure if it was me. I can just continue until she comes back. If that's all
Okay.
right. Um, and I don't have Brittany's notes, but I can tell you that just the education is really helpful. And most states have a brain injury association, but the Brain Injury Association of America, BIAUSA.org, is kind of a resource to figure out if your organization does have one of those. And Brittany's back. So Brittany, I'll let you continue.
I don't know where I stopped or what you guys heard last. So I'll just jump into talking about education. That's also an important way to assist yourself, making sure that, again, you learn about brain injury. What are common symptoms? What are things to expect? And also not being afraid to teach family and friends about brain injury. So you also serving as a teacher in that space and seeking out resources with brain injury education is also important. And we have some resources there to look at. And the last one, again, utilization of community-based resources, building a team for yourself and loved ones is super, super important to include both natural as well as professional supports to make sure that, again, you have those wraparound services. And I believe we're going to transition into case scenarios.
So I think Brittany, you and I will kind of tag team these. I'll do
Okay.
case number one. So these are actual clients that we've worked with, and we're going to have you put your knowledge that you've just learned and maybe was reviewed for you to the test to see how you would work with each individual. And we have a list of questions after each scenario. And so this names have been changed, obviously, but this is based on a client that I worked with several years ago. And he was referred to me from one of our day programs, and he had had a stroke about 5 years before he was referred, and he has expressive aphasia. Um, I had never worked with someone with aphasia before, so it is definitely something that you have to think a little bit differently about. So what was noted was increased depression, um, and he had been going to the day program for a while, so they did know him. And he talked a lot when he was able to share some things about his job that he had not been able to return to. And he was working on some things at the program to try to move back into that arena. And he also was frustrated with his relationship with his ex-wife. She was very helpful with him and after his stroke, but they were not together, and she didn't feel the same about the relationship as he does. So I summarized it for you, but hopefully you were able to read some of that as well. And I believe you also have the handouts that you can go and look at this again. I'm going to give you a few minutes to put in the chat how you would accommodate this client's disability. So remember, he has aphasia, expressive aphasia. What interventions would you use to communicate with this client about his symptoms and gather additional information from him? And what interventions would you use to treat this client's symptoms? If you don't mind monitoring, I'm going to try to see the chat as well, Brittany, but if you could, when it seems like people are done. See what people come up with.
So we have, again, the suggestion of the use of visual aids. Writing things down, assessing facial expressions, sign language, so able to learn emotion cards, role play. Emotional scales.
Any additional? Should I go ahead and comment?
And the last one, collateral contacts. Yes. Use of additional folks on the team, modeling, repetition, compiling communication booklet for common language you might use.
Mhm. I'm gonna, you can keep sharing, but I'm going to just kind of make some comments. The scaling is kind of what I did, offering choices or asking him to rate his feelings on a scale is he could do that. He could, if you said to him 1 to 5, he could repeat back where he was coming from. And sometimes I would, I think I actually may have asked some questions from a depression inventory. I just made it kind of a verbal. I did it orally with him. And he was able to say the first one or the second one so that I could get an idea. Definitely collateral contacts. He was in a day program. They knew him pretty well. So they could, when they made the referral, they had given me some background information. Um, he had an communication board, like an iPad type of a thing. He didn't like using it, which makes it a little bit harder. And so, again, meeting the clients where they are, you have to, just because they have an augmented speak device doesn't mean they're willing to use it or like using it. Um, I did want to make a comment about the facial expression. He did have a stroke, and so he didn't have facial expressions that necessarily indicated how he was feeling because he had muscle weakness. And so he did kind of, he could present as depressed even when he wasn't, because he had a very flat affect. Um, but there are some times when, if there's a difference in what I'm seeing, it might be an indicator that he's feeling better. When he didn't have if he laughed at something or whatever, I could really pay attention to what was different from when he was talking about feeling sad. Um, and I think that covers a lot of what you said. Those are the main things I did. He was my first aphasia client, so it took a bit to figure out the best way to work with him. But he made some decisions during our time together, including kind of how to move forward from his relationship with his wife that had changed. And so it could be difficult sometimes to figure out, does he understand me? But I knew he didn't have receptive aphasia, so that kind of information was helpful. He didn't have memory issues, so for him that wasn't one of the symptoms. But there are a lot of things you got to do with somebody with aphasia to get to that point, and all of your suggestions were excellent. I'm going to move on to the next one. Brittany, do you want to do this one? I know it was my client, so it's up to you if you want me to elaborate, but if you want to kind of summarize
No,
what
you
it.
can do 2 and I'll go ahead and do 3.
Okay, because that's yours. Okay, so this again, different name, but this is a client who was injured at a young age. As you can see, had lots of plans in his life. And when I met him, he was in his early 40s. He did attend college, but he really, really struggled. And he didn't obtain the degree he wanted. He kept calling it a like a pity type of thing. And he worked really, really hard. But his primary issue, besides anxiety, he does have anxiety, and that's why he was referred. And anxieties would trigger seizures for him. So this is a real concern. He was referred, and what happened was he will repeat himself over and over because he has very poor short-term memory. And he frequently reiterates his story about his college experience and failing and not being able to work. And you can imagine for him, um, he's reliving it over and over and over again because he doesn't know how to move past it. Um, he also was anxious because his parents were elderly and he was really concerned. One of them was very, very ill at the time. He was really concerned about what would happen when one of them or both of them were gone. And he just really wanted to be able to do more. He's friendly and polite, but he was often anxious. And sometimes he would really go into a spiral, and that would trigger a seizure for him. He has a strategy, but I'm just gonna see if you can answer some of the following questions, and I'll tell you a little bit more about him. So, what questions would you ask to identify whether both the cause of the symptoms are brain injury, mental health, or both? And how would you accommodate his disability? What interventions would you use to treat this symptoms? Feel free to put it in the chat.
Joy, can we flip back to his actual case
Oh,
scenario?
I'm sorry. Yeah. And
And
I
so we
can
have,
reread the
okay.
questions. Yeah.
So we have some
So
questions about when did he first begin to experience depression or anxiety symptoms, as well as what provokes the anxiety.
okay. He was he had the anxiety symptoms probably for a few months at the day program, and they were getting worse. And it was usually centering around that concern about not being able to work and concern about his parents.
Okay, so questions that folks would ask again, just the onset of symptoms, some interventions, mindfulness, breathing techniques, coping skills, gathering more information about daily routine, and working to ensure client is receiving wraparound services,
Hmm.
getting information about medical history, triggers. They want to know if he was taking medication for anxiety,
He was.
senses grounding. Um, a question that would ask, did he struggle prior to injury with anxiety?
So also keep in mind that he has very poor short-term memory. So we would have to go to outside sources to get a lot of the information, but we could talk to him about what's going on in the moment. But he's not able to, he's a poor historian. He's not going to be able to give you any information about how his week went or anything like that. So, how would you accommodate his disability? And what interventions would you use to treat his symptoms?
Session journal. So what's happened in the previous session was a recommendation. There is a question about is long-term memory intact?
Remote memory is intact, meaning, because he was injured many years before. And so he could remember a lot of things prior to the injury very, very well. And some of his long term memory was intact, in that he did build memories after that. But his short term working memory was pretty much nil.
Mindfulness, writing down coping skills, as well as grounding statements, staying in the present, mindfulness. There was also a comment about utilizing family and providers to gather additional history.
All excellent suggestions, for determining when did this anxiety start. He was so young when his injury occurred that sometimes, there are things that He could have had a history of anxiety, but there are some things that could have just been happening because of his situation as well. And so we do need more information. Was he taking, medication before? He did not live alone, and he did have a family caregiver who was working, could definitely share a lot of information. He had been going to the program long enough that they could also talk about, when these things would come up. So that information was really helpful. The journal, um, he kept, so his memory is a series of calendars, pocket calendars, and he has volumes and volumes of them. So that assists him. He probably will always need the accommodation in order to have any history at all, to be able to say what he did yesterday, an hour ago, last week, years ago. He keeps all of those. But what was really helpful with that is that he could write every single day on his calendar, because that's what he relied on. He would look at every day of his calendar to see what he was supposed to be doing. And I would have him write the suggestions that we worked on each day of the calendar to work again, repetition, 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 so that he could work on whether it be mindfulness. In his case, he was into meditation. He liked reading scripture. And so he would have things that he would write on each of those. I would have him come up with what was helpful for calming him. And so he would write them on each day between our sessions. And so it was like having a session journal. For him, that was the thing that he would look at. For him, an extra thing might not work well. But it's the same idea. So really good suggestions. And then, just the typical um, anxiety treatment. Yes, absolutely. The biggest challenge for that is that he would forget to do it or forget what was suggested. And so that's where the journal is super helpful. And or in his case, for some people it works to have it on a phone calendar. Some people need paper, some people need both. Very individual. Anything else that I didn't mention, Brittany, that came up in the list?
No, it was funny as you mentioned that, or we're talking about the calendar. Someone had just noted the note strategies, the written phone apps and reminders, and it
Yeah.
sounds like you rely very heavily on those. So,
Yeah, that's what our Compass program does, which is our OT skills building. They help clients find apps and things like that. And for some people, it's low tech. It's not high tech at all. It's things like exactly what you're talking about: calendars, notebooks. But for some people, alarms work, and for some people, they don't. So very individualized. I'm going to move on to the next one because we want to also have time to have you guys ask questions and answer some of those. Go
okay.
ahead.
And so this is Miss Rachel, and I'm just going to read the scenario out to you all and let it kind of sit with you all, and then we'll ask the question similar as we've done, kind of one by one to give you guys opportunity to answer. So again, Rachel, 60-year-old mother of one adult daughter, presents with anxiety related to her daughter's health. Her daughter sustained a severe TBI from which she's still recovering approximately 2 years prior to Rachel beginning therapy. Her daughter can communicate, has learned to walk with assistance, and is coping relatively well with her post injury life. However, her daughter has what doctors have stated are likely permanent physical and cognitive disabilities that Rachel is not convinced are permanent. Her daughter is in a long term relationship that Rachel does not feel comfortable with and often blames her daughter's partner for her daughter's lack of progress and frequently argues with her daughter's partner, causing conflict with her in her relationship with her daughter. So let you guys kind of take all that in about Miss Rachel. And so again, this is an actual client caregiver that I am working with. And the first question we want you all to sit with and kind of think about is, how would you assess the client's symptoms and need? So thinking about Rachel, teasing out what's her issue, concern compared to what her daughter has going on. So what would you do to assess her symptoms, her needs? Or what do you identify as maybe symptoms and needs of Rachel? So Rachel is the mother. Okay, so some thoughts we have here, I believe, I think Autumn, this is connected to this one. Support group, definitely think she's angry, denial about what's happening to her daughter, absolutely. Working with a collaborative team, grief loss, conversations, yes. Lack of control, that's very big, yep. Stages of grief. And absolutely, as far as again, what are the symptoms? What are the needs here, Rachel? And so, just a little bit about in my start with working with Rachel, that's kind of where we are as far as focusing on what her area of control is. Self-care, absolutely, that's a big one that we're talking about and really working through the stages of grief. Rachel is very angry about what happened to her daughter. She feels out of control, and she is also in denial about where her daughter is post-injury as well as her recovery goes. And so that's really hard for her to sit with too. Um, Family sessions for Rachel to hear her daughter, vice versa. Absolutely. Education, yes. On TBI, absolutely. Team meetings, yep. Those are very much in play with Rachel. And Joy and I actually we work together on this case as Joy works with the daughter. So yes, collaboration is huge on this case. Um, Very important point, Sarah. Her daughter is not hers to control, and that comes up a lot within session. Control is very, very big. And also, too, again, her daughter is an adult and she's able to make her own decisions. So and she struggles with respecting that boundary. So absolutely, that's huge. Yes, yes,
Go ahead.
absolutely. Understanding that her daughters are own and able to make her own choices. Absolutely, yes.
There are those who cannot, but in this case, I mean, there are people, unfortunately, whose family members are not able to make their own decisions, and guardianship has been implemented, but not in this case. She is her own, and I think she is really struggling to recognize that um, this is permanent, but her daughter is also doing relatively well, but not on her mother's terms.
Yeah, yeah. So a lot of psychoeducation, bringing it back to refocusing on her needs. Again, her sessions being about her, her own self-care, her own grieving, and coping with that anger as well as depression. There's something that Rachel struggles with as well as depression, just re-engaging in life. The first 2 years following her daughter's injury was all about her daughter's stability. And now that her daughter has a measure of stability, it's supporting Rachel with letting go and allowing her daughter to live her life. And so that has been hard with that letting go piece. Any additional interventions that you guys would use to address the grief, the anger, the struggle with control, the boundaries, um, as well as resources that you all might offer? Yes, activities to do, absolutely, as an extension of what the therapist is doing within the work with the daughter. Let's see, education, psychoeducation, yes. Caregiver groups, absolutely, yep. And more about psychoeducation, yeah.
And a lot of this is what you would do, not just with brain injury, of course, but I think that again, back to some of what we talked about and what Abby Maslin's quote, it's sudden. And that's, one thing that I've, when I've worked with caregivers, it's almost always, with the exception of our pediatric program, some of those, we only work with acquired brain injuries, so it has to be after birth. But if it's very, very early in someone's life, it's been a way of life for a long time for the caregiver. Um, Although we do work with people very early as well. But we do have people where the person becomes an adult. Brittany and I also shared one of those people that the young man had his brain injury from a young age or younger, he wasn't very old when it happened. And I was working with a caregiver. And so they were in a routine of, you know, he was still a dependent. He was never really launched at that point. And so that's a little bit different, quite a bit different. Not that it's easy by any means, than the person whose adult uh, child child was launched, was out on their own, and then suddenly they're back in that caregiver role. And it is just this weird place to be back in that. And that's where that grieving process, it's shock at first, and then having to jump back into that role and knowing how to do that role. In this case, there was some pre-injury conflict as well. And so that has entered into this relationship post injury, and maybe making up for some things, and we don't really know, but we can speculate. And sometimes there's still, on the part of the person with the injury, that desire to be independent, as they were before. They were living a whole life without their parents for years, and then suddenly, thank God, they had someone to come in and help out the partner. But at the same time, it's an awkward transition, and it's hard to let go when it's time to let go again. It's like you have to do it again. It's really hard. So I just wanted to make that comment. And I really appreciate all the feedback that you all have given and some of the suggestions, and you're right on. I think that either you already knew this stuff or maybe we helped a little bit. We are going to take a little bit of time. I'm just going to share a reference source page, which you have, and also the questions. That's what I want to be able to kind of open it up now to answering any questions, but more specific questions that you might have.
And there was a question early on, and I just made a note of it about tech advancement and brain injury, I believe, recovery. And if you want to ask that question again, please feel free. I know it was very early on when we started. And so if you're still thinking about that question or had jotted it down, please feel free to drop it back in the chat.
I put it back in the chat. I had copied it.
Oh, perfect. Thank you, Mary. And the question was, do you think over time tech will improve enough to be able to see the more mild many forms of trauma occurring in the brain?
Can you read that one more time?
Yes. So do you think over time technology will improve enough to be able to see the more mild many forms of trauma occurring in the brain?
So I'm
Agree.
guessing, I may be wrong, that this is sort of related to sometimes they're not picked up on scans. Is that what you mean, or are you talking about accommodating brain injury with
It's
technology?
more so I believe the technology to actually like see it occurring, correct? Like with scans, and I'm
Okay. I hope so. I know there are other types of scans, like PET scans, that can pick up things that CAT scans cannot, CT and MRIs cannot. I don't know of anything that picks up a TIA, the mini stroke. Um, and I do know that sometimes the concussions aren't picked up. We didn't talk about multiple concussions. That's a little bit different. I think that once someone has if someone has multiple concussions, it's possible that they would be picked up over time. Um, I think sometimes it's the symptoms. It's not getting what's difficult with that is sometimes you need a medical diagnosis to get services or get disability, et cetera. But symptoms, and that's where the neuropsychological evaluation can be really helpful. And they will, Social Security, disability, they will use those types of tools sometimes if there isn't a scan that identifies it. It's just evidence that there was a change. Um, I know we have asked for them before, and our our state rehab organization that provides a lot of our funding, Department of Aging and Rehab will also order them. They do the vocational piece for clients who want to go back to work. And so that is used as a way to at least evaluate symptoms, even if we don't have the scans. Anybody else? Anything specific to someone you've worked with or anything like any questions for us about anything we know about brain injury, I guess, that we didn't cover?
Question, are seizures considered non-traumatic brain injuries at all?
Seizures can cause damage, but in and of themselves, we don't usually consider those to be brain injury, but I would defer to a neurologist to really answer that question accurately. We know a lot about brain injury, mostly because, well, we have standards for, we have to have a diagnosis for people to get our services, but we also, we have had clients who have seizures as a result of a brain injury. Um, but it can also, repeated seizures can also cause more damage. So to get an accurate answer, I would look that up from a neurological perspective. Anything else? An early.
There is a question that says, what is the 10-year mark?
I'm not sure what the 10-year mark is.
Sarah, maybe you can expand on that question.
I will say that there is a period of time that a lot of neurologists and neuropsychologists will use as the period when the most recovery occurs, and that's usually 2 years. And it doesn't mean that there can't be progress after that. So I'm not sure if you're referring to something like that, but I haven't heard of the 10-year mark before.
It says I have been told that things change at the 10-year anniversary.
I have not heard that. And in all my years of working with people with brain injury, I've never actually heard that said. Um, it could be that individuals have noted that, but I haven't actually heard that. The 2-year mark is definitely something I've heard from, across the board, that the most progress, the most rapid progress takes place within 2 years. But I also don't like to put a timeline on that, because we've seen progress after that, lots of progress. Sorry, I can't be more helpful with that. It's not one I've heard.
Okay, so can anoxia be either traumatic or non-traumatic injury?
Anoxic is a non-traumatic injury because it's not, so I can understand the confusion because it is coming from an external source, but it's not a traumatic brain injury. Has to be an penetrating or internal, or a blow to the head. And so anoxic typically is considered a non-traumatic brain injury.
And have you ever worked with a BI client whom you noticed was getting better cognitively then regressed over time?
Unfortunately, sometimes there's more to the story, but there are people who also end up with dementia, declining dementia. And there are some studies that show that people who've had TBIs are more likely to have dementia later in life. And it may be a number of TBIs, not just one. And certainly if they didn't recover versus if they fully recovered, that's different. Um, typically brain injury itself isn't a declining type of a thing. There's usually something else going on. And sometimes brain tumors occur after having had a TBI years before. I've had clients who've had that experience and they were told that the tumor occurred because of their TBI, and that can cause changes. But most of the time, that my experience is that it's usually another diagnosis. It's not the brain injury itself. That's usually the difference. Is the brain injury is kind of eventually it stabilizes, but as people age, it can kind of exacerbate some of normal aging and dementia that maybe would have happened anyway.
Um, what if the injury occurred long enough ago that we don't know the pre-injury functioning? Is there a way to evaluate what symptoms are brain injury versus other neurological or mental health things?
And Brittany, feel free to jump in as well. I mean, I would still go back to gathering as much history as possible. And a neuropsych can also help with that. Sometimes will also gather enough history to find out if what they're seeing is different from what happened when they were younger or in school or before the injury, when depending on when it happened. Brittany, do you have any other insights about that one?
Sorry, no, I'm just tracking things for you. But yes, no, I would agree with that. Gathering as much, again, just history as you can. And if you know the questions to ask about teasing out possible brain injury, of course, can be helpful.
Right.
But then someone also commented, yes, it's hard to isolate symptoms. I know that was related to an earlier question, but that can also apply to Colette's question as well.
I will say that we've asked neuropsych because I've worked for this organization for about half of my career, and it's over 25 years of a career, so long time. And I was a case manager years ago. And from that time, and even more recently, neuropsychologists will say sometimes you cannot tell the difference between brain injury and mental health. It's really, really hard to know. Obviously you're not always going to get accurate information, but even if you do, some people don't realize that there was a developing mental health issue, or they didn't have it treated, or I didn't identify it, and it became so exacerbated after injury that both are showing up.
Absolutely. So, Colette, did that kind of speak to your thoughts about, say, it occurred while they were a toddler, and that's what Joy was saying it could have happened so long ago, but again, due to that unaddressed injury, it could have exacerbated mental health concerns, and that's what you're seeing as the primary or what's now manifesting. So it is kind of hard to pinpoint, and that at that point in time, we do want to just focus on that symptom management to support them with improving functioning.
Yeah, and sometimes when an injury happens when somebody's young, we really don't know what would have happened if the injury hadn't happened. I mean, there are always going to be those mysteries of would they have had
Yeah.
this issue without the brain injury, and we may not know. That's hard, but it is, like as Brittany said, treating the symptoms is really the primary focus at that point.
And I want to go back. I think I missed something. Let's see. In your experience, any advice with folks who have memory loss due to TBI, who now have cancer, and working to remind them of their illness in a way that is productive or advised?
Mm. Can you read that again? I'm sorry. I wish, I'm afraid if I pull them up that everybody can see them, and I don't necessarily know if everybody wants that, but
Um,
um,
in your experience, any advice with folks who have memory loss due to TBI, who now have cancer, and working to remind them of their illness in a way that is productive or advised?
okay. So, in other words, they're forgetting things that are really important to remember as you're working with them to address issues. I mean, I think sometimes, again, meeting people where they are and focusing on the symptoms at hand, but then people do forget really important information. Sometimes they forget important information about others as well. And so it's tricky. It's not necessarily easy to do, but approaching with compassion, and when somebody really does need to know the information, that it's you may have to remind them of painful information that they've forgotten, in order for progress to occur. And if they're experiencing illness, I mean, that would be pretty significant, memory loss if they're not remembering what's causing it. There's also those visual prompts, the things that could be gentle reminders of kind of what they need to be doing, to treat it might help, and just to know, this is part of your life now. I know sometimes it can be challenging when someone has an additional illness and they forget, or they don't realize that they haven't accepted it, or they just really don't know, how to care for it because of memory or whatever the brain injury issue is. Executive function. As you can see, I mean, we've been doing this a while, but every situation is so unique. And so every person is so unique, every situation is so unique, and that's no different with brain injury. It's every time Brittany and I meet a new client, it's a new brain injury. We definitely know more how to work with certain things, but we have to really kind of, just like any other client, meet them where they are and try to figure out, kind of problem solve, which makes all of our jobs challenging. And try to figure out, how do I work with this combination of problems?
Absolutely. And thank you, Sarah, for sharing for what she dropped into the chat.
Mary, how are we on time?
You've got about 5 more minutes, so if you want to ask some open-ended questions, feel free.
Okay. Does anybody have a client that they think might have a brain injury, but maybe doesn't know they have a brain injury, that the client has never revealed that, or you're wondering?
Hmm. The client with active military history, history
Mm.
of post-traumatic stress disorder.
Mhm. And a lot of military, do come back with TBIs, and some have the more diffuse with from the explosive, the blast injuries, and
Yeah.
PTSD as well.
Seeing comments about working with military veterans and wonder about potential injury, or just a client that they were told they were not injured. But it sounds like the individual working with them has questions about that.
Mhm. And I would encourage, again, ask, maybe not do you have a brain injury, but the other types of questions that I had listed earlier. Have you ever had any big accidents, any major life changes, any changes in how you're able to do things, kind of trying to figure out if there was a treatment or a hospitalization that could have been a brain injury. And sometimes you don't know, and you still have to, try to figure out, is this person resistant, or do they have poor executive function? Are they, not remembering from week to week what I'm saying? And there could be a conversation that's needed about, it doesn't seem like, you're remembering. Is there any chance that you ever had a head injury? Not everybody who has a head injury has a brain injury either. So that's something to think about. I have one client who says, I had another brain injury because she hit her head, and she's no different than she was the last several times. So there is some education about that. I probably should have mentioned that just because someone's hit their head hard, a lot of times people do fully recover, and if they're not diagnosed with a concussion, it's not always a brain injury. But there are other reasons for executive function issues as well. So it might not be what you're seeing, but it would be really helpful to know if there was an accident or a fall or something.
So two thoughts. The first thought, someone said I had concerns about Delusions about now, but now I'm relating it to trauma. They're beginning to share, referencing the client. And then someone asked a question about accelerated resolution therapy and would that work with brain injury? Um, we're specifically
Okay.
working with veterans who come back from war.
Do you know what accelerated resolution therapy is, Brittany? Have you heard of
I
that?
am not versed in that. I haven't used it personally, no.
Same here. I don't know that one. I'm gonna write it down though.
Sarah said it was like EMDR.
Oh,
Ah,
okay.
okay.
I will say that some clients with brain injury don't do well with the MDR because of sensory issues. Sometimes it's overwhelming. The different steps are overwhelming. Um, I've had clients that did just fine with the MDR, but others, especially with eye movement, can make them dizzy. I mean, there's different reasons.
Mm,
Um, but it again, very individual, really depends. Sometimes some of those dizziness issues and movement issues and visual issues can really impact some of the things that we might do, including even showing videos and um, doing like a guided meditation. I had one client who just said that even thinking about a moving stream was making her dizzy. Um, it just really depends on the person.
mm.
So even though some of the symptoms are similar, each individual experiences those symptoms very differently or can experience them very differently.
For those reasons, Colette shared that it may be contraindicated for those with seizures.
Okay.
I think this has been a wonderful session with a lot of learning going on in it. And I want to thank Brittany and Joy. What a great presentation. I put the survey link in the chat, and so you can click on that right now. I will be sending an email with the links from the session, the survey link, and the link to the slides. And I'll get that out within the next hour. Check your confirmation or reminder email for full CEU requirements. And let's see. Oh, and your evaluation needs to be completed in 2 business days. So Monday by 1 o'clock, it's closing. So get your answers in now. And you can direct questions to the Empower Idaho email that I'm thinking Eden will put up in the chat box. And the slides and recording will be available on the website in a couple of days. Thank you again, Joy and Brittany. What a great presentation. And thank you everyone for attending. It was a great webinar. Have a good day, everyone.